So, good evening, everyone. I welcome you again for another webinar of ours. As you all know, it's part of our centenary celebrations. And this time, our very own Dr. Salman Akhtar is here. With his gracious presence, he is consented to be our speaker. So I welcome him, and I welcome all of you from Delhi, Bombay, and abroad. So please just enjoy yourself with his talk. I'm very happy that our very senior member, Minnie Dastoor, is here and she consented to chair the webinar. And now I pass on to our president, Dr. Pushpa Mishra, to welcome you all.
Good evening, everybody. And I don't know what to say about people who are from different countries, where it could be morning or afternoon or night. So whatever it is, appropriate greetings to all of you. And as our secretary has said, we are actually proceeding towards the end of our centenary celebration. We started it on 26th January 1921, and we will end it on 26th January 1922. So this is the 9th lecture in the series, because we have held one webinar every month. And we have with us Salman Akhtar. About Salman Akhtar, our chairperson, Dr. Minnie Dastoor, will say. But I would like to just share one thought and one fact, in fact. What you will listen today as a psychoanalytic lecture is your gain. But an additional gain will be that Salman has a very lyrical quality in his books and in his lecture also. I was just telling him that I still remember the 2-day workshop that he had given us, and we had enjoyed it immensely, more so because it was interspersed with Urdu Shairi, of which he knew, and he has probably an enormous amount of Shairi in his store, in his memory. So enjoy the lecture, and I hand over the mic, so to say, to Minnie Dastoor, who would introduce our today's speaker, Dr. Salman Akhtar. Over to Minnie.
Thank you, Pushpa and Bharati, for this wonderful year that you all have arranged to have a webinar each month, calling people from all countries. And it's been a great achievement for our IPS. And today, it's really delightful for us to have Dr. Salman Akhtar with us. And thank you so much for sparing time for us, Dr. Akhtar. I'm just going to say a brief biodata about Dr. Akhtar, because it can run into just pages and pages. And I think we are much more keen to hear him. But apart from just a few necessary things, I would like to take some excerpts from his book, Dancing with Words, which seem to me to say very much more about the man, which we are interested to know about, the man who's the psychoanalyst and the poet and the storyteller in a way. Now, Dr. Salman Akhtar needs no introduction, certainly not in the world of psychoanalysis, where he has carved a notable niche for himself, right on the famous Chestnut Street of Philadelphia. His journey through life has made him a man with eclectic background, right from his childhood, steeped in the culture of his parents and grandparents in the rich and beautiful literary Urdu tradition of northern India. It goes back in a long line of generational transmission. His great-great-grandfather was a poet and scholar of Islamic studies and theology, grandfather a poet, father a poet and a singer, his mother a teacher and a writer, and it now continues down the line to his son, an Emmy Award-winning screenwriter and editor. Regarding his biodata, from leaving the shores of India after doing his MBBS in Aligarh University, internship at Maulana Azad in Delhi, and postgrad in Chandigarh, and he repeated his medical training in the University of Virginia in '76, and his psychoanalytic training from the Philadelphia Psychoanalytic Institution in '86. He's currently professor of psychiatry and human behavior at Jefferson Medical College and psychiatrist at Jefferson University Hospital, plus being a training and supervisory psychoanalyst. The rest, I would refer all of you to see pages and pages in Wikipedia or YouTube or wherever. However, I found something much more interesting and telling as I browsed through Dr. Akhtar's several publications that tell of him as the man he is, and maybe the psychoanalyst who works with his patients and with his particular being of the man who he is and the man that he carries through his generations. And it is from his book, Dancing with Words. He says, there is a two-word answer to the question why I write. That is honest, simple, and devoid of affectation and posturing. And those two words are for pleasure. He then goes on to write of 6 kinds of pleasures. 1, the pleasure of sublimation. 2, pseudo-sublimation, which he honestly accepts as motivated in search of fame and recognition, and why not? Who doesn't? And it reminds me of Shakespeare's famous lines, to thine own self be true, and then it must follow as night the day, that thou canst not then be false to any man. At the last count, he states 396 publications, and that's quite a prolific outburst of creativity. Number 3, he talks about pleasure of filiation, carrying his love and pride in his parents and in his culture. He says, each page I write is a handshake with a beloved family member. Each book, a red rose laid on the grave of an ancestor, and each edited volume, a family dinner. If I was in Awadh, I would have said wah wah to those lines, as it should be. Then he talks about the efficacy and problem solving, the pleasure of that. He lists forgiveness, regret, and immigration that have occupied his interest. I have found regret and forgiveness as absolute necessities if one is to free oneself of the chains of psychic bondage, and I think also free our patients of their particular psychic bondage. He then writes about the pleasure of passively becoming the instrument of powerful reparative forces, an act of faith, where some of our accurate interpretations come spontaneously to us without premeditation and as reveries. And I find that the more and more I work, I rely on these memories, very much as Ogden or Pharaoh talk about. And I think Dr. Akhtar talks so vividly and describes so much in his work. And I think that that is maybe the new way. Maybe that's part of your facilitating environment, Dr. Akhtar, that you're talking about in a way like Winnicott, something more than interpretation. Now, I'm not going to take any more time, and over to you, Dr. Akhtar. We are all agog waiting to listen.
Thank you so much for this kind introduction. Bharti, I just got to know, but certainly both Minnie and Pushpa I know from before, and both very respectful and fond of. Let me begin this talk by some introductory ideas. One is, and this may be elementary, but it never hurts to start from elementary things. See, when Freud went from the first dual instinct theory to the second dual instinct theory, for the younger people in the audience, just to remind them that the first dual instinct theory involved a sexual instinct and a self-preservatory instinct. Sexual instinct, which worked predominantly unconsciously and was intended for the propagation of a species. Self-preservatory instinct, which worked predominantly consciously and was intended for the advancement of the individual. This was the original theory. Aggression at that time was a partial product as a response to the threat to the self-preservatory instinct, or as a component, an erotic component of the sexual instinct. It was not an instinct by itself in the first model. In the second model, which Freud proposed in 1920, beginning in Beyond the Pleasure Principle, he proposed that there were two major instincts which were providing the fundamental motivational substrate to mankind. One was life instinct and was death instinct. Life instinct constituted of what were hitherto sexual instinct and self-preservatory instincts. So those two instincts of the first theory now came to be subsumed under life instinct. Death instinct, Freud proposed, was an early primary longing to be rid of the tension of being alive and the responsibilities and the mentation and the affects and ambivalences of being alive, and hence return to an inorganic state, an state of entropy and non-being. This was, and then later, of course, various analysts elaborated on the fate of the death instinct. The fate of the death instinct predominantly became an externalization and creating bad objects and aggression, or binding by the libido inside, and therefore creating primary masochism, and also unneutralized instinct dripping inside oneself, leading to vulnerability to autoimmune disease. However, just as a footnote, Freud used the word death instinct sometimes in singular and sometimes in plural, which is a very interesting thing. And I've written about it. What does he mean when he uses the word death instincts? Does he mean that there are many kinds? And if there are many kinds, are there good kinds and bad kinds, and so on and so forth? I have written about it, and those of you who are interested in this matter, I will be glad to give you the reference. The reason I lay this down, the basic conceptual backdrop to what I'm going to say, is that what ended up happening once Freud's second dualistic theory got introduced and picked up by the mainstream psychoanalysis, that the Freudians started to be more and more interested in the sexual component of the life instinct. The Kleinians got more and more interested in the aggressive aspect of the death instinct. And the ego-preservatory instinct, self-preservatory instinct, self-protective instinct, or what was also called ego instinct, got dropped. The Kleinians focused on the vicissitudes, externalized and re-internalized vicissitudes of death instinct. The Freudians of sexual instinct, or to put it correctly, the sexual component of the life instinct. And the second component of life instinct, ego instincts or self-preservatory instincts, got sort of neglected in psychoanalysis. Because, as Freud himself says, the repressed has a continuous pressure, or the repressed exerts a continuous pressure in the upward direction of consciousness. That applies to individual psychic life, that applies to groups, that applies to conceptual ideas. Because the concept of ego instincts or self-preservatory instincts or self-protective instincts or self-advancing instincts, which were all different names Freud had given in 1905-1915 period to that instinct. Because that got dropped suddenly and abruptly and rather totally by the time the second dual instinct theory got adopted, it got repressed. But repressed exerts a continuous pressure in the direction of consciousness. It needs to be picked up. And that appeared in the work of what was then labeled the independent tradition, British independent tradition, in the work of Winnicott, Ballant, Guntrip, and to a certain extent Masood Khan, Christopher Bolus, and so on and so forth. This ego instinct, which was a slow-moving instinct, and often a conscious instinct, got a kind of a theoretical exposition in the works predominantly of Donald Winnicott. And in United States, where people had not read Winnicott and balanced carefully and had become, totally and rather blindly Freudian and neo-Freudian, and in Latin America, the opposite, Kleinian. But therefore, in United States, the independent tradition was not read, not understood, not followed. But the concept is human. The concept is present in the mind, in one's own mind, in other people's mind, in the doctor's mind, the patient's mind, and therefore had to be rediscovered. And this reappeared in a typical American way in the work of Heinz Kohut through self-psychology. Okay. What does it all have to do with what we are going to talk about? What it has to do with is following, that psychoanalysis, deals with transference and interpretation in the setting of anonymity, abstinence, and neutrality. Now, when we say transference, what do we mean? There is a classical definition of transference, which is okay, which is not wrong, which is, I think, applicable 82% of the times, or maybe 82.4% of the times. And that is that, oh, by the way, just to let you know, please, and Bharti, you keep an eye on this, don't listen to me with 100% seriousness. You will be lost. I'm not the kind of a speaker that has to be listened to with 100% seriousness. About 79, 81% is enough. Then you get the idea. If you get too serious, then you'll get lost. Anyway, that the major definition of transference is an unconscious recreation, perhaps inappropriately, of childhood actual relationships or imagined relationships or dreaded relationships or defenses against those relationships, as expressed, as hidden, as verbalized, and as non-verbalized, with formative figures of childhood, which in a nuclear family context are mother and father, but that is not true of many other cultures. They can involve uncles and aunts, they can involve grandparents and older siblings and uncles, and so on and so forth. So an unconscious recreation, somewhat inappropriate, of childhood or the formative years, internalized relationships and defenses against them. That is what is called transference. It happens outside of treatment, it happens inside of treatment. The difference is, inside of treatment, we examine it, we question it, we try to put the patient in touch with it so that the patient can begin living in today rather than living in yesterday. Now that is okay and good and correct definition of transference. However, with the work of Winnicott and with the work of Ballot and then of Guntrip, and then in this country of Heinz Kohut, and before Heinz Kohut of Hans Lowald, I think a new perspective on transference appeared. And the new perspective on transference appeared is related to what I had just talked about, ego instinct, self-preservatory instinct. The classical definition of transference pertains to sexual instinct and aggressive instinct. The new definition of transference pertains to the ego instinct or self-preservatory instinct, which implies that there is an internal pre-conscious awareness in a human being of what is needed for one to become oneself. What is needed, who is needed, and what is needed for one to become oneself. The best one, the most honest one, the most authentic one can be. It is the transference definition derived from the concept of the ego instincts that gives rise to a new definition. And that is that transference is a search, unconscious search, unconscious and pre-conscious search for objects, environments, people, things, disciplines, fields of studies, pieces of literature, art, and music. An unconscious search for experiences and objects that will unfold the thwarted development and make one grow more and more into what one is intended to be and what one wants to be. So, as a footnote, obviously, there are, the traditional saying is that no matter which analyst you go to, the outcome in the end is the same. I don't agree with that anymore. I think you see a Freudian analyst, something happens which is different than you see a Kleinian analyst, and something happens different than if you see a Winnicottian analyst. These are the three major schools, and then there are, of course, other subsidiaries. But in Freudian school, the work is focused upon the vicissitudes of the sexual instinct and predominantly its Oedipal ramifications. And the work often leads to a kind of restraint, civility, rationality, and I fear also conventionality. The Kleinian analysis, I think, leads to a sense in the end to recognition of one's own contributions to the aggressive problems in the interpersonal matrix, and therefore it ends with a person being humble, being modest, being full of gratitude towards goodness of life and offering reparation. The Winnicottian analysis ends with a person with becoming more authentic, more playful, more risk-taking within limits of civility and physical safety and such. Take just example of Paul Gauguin. I mean, if Paul Gauguin was a rich privy councillor in Vienna, married with some 10, 11 children, I don't know, more than 8, 9. And he had money and such. And then one day he decides that he'll go become an artist. So he leaves his money and everything to his wife, starts painting, and then he is restless. And then he paints there. Then he moves around in Europe, and then he ends up for briefly in Hawaii, and then he moves further up in Tahiti and dies of syphilis while making great contributions to the art. Now, imagine if Paul Gauguin had a Freudian analyst, and imagine if Paul Gauguin had a Kleinian analyst, and imagine if Paul Gauguin had a Winnicottian analyst. I think two of the analyses might have prevented him from leaving his wife and children and going away and becoming an artist and moving so far away from his land and such. Possible. Something to think about. So what I'm going to talk about is that besides the interpretation and reconstruction of transference as related to sexuality and aggression, which obviously form the meat of our work. Besides that, there are transferences and developments in the interpersonal matrix of clinical psychoanalysis that emanate from ego instincts. And they have to be handled differently by what I call development facilitating interventions. Now, here is a caveat. And that is that these development facilitating interventions are not replacements of confrontation, clarification, interpretation, reconstruction, No, they are not replacements of traditional analytic work and customary analytic work. They are additive elements. That's one. Second caveat, they do not overlook the triad of the guideposts on which all analytic work is based: anonymity, abstinence, and neutrality. So we have to stay in that position, the therapeutic position of anonymity, abstinence, and neutrality. We will be using reconstruction, interpretation, clarification, and such. All the traditional analytic, customary analytic method is not thrown away. What I'm proposing is not an alternate to that, it's an addition to that. And the abstinence, neutrality, and anonymity is not given up. It may be modified, but it's not given up. Also, that the tension between the clinical role of the analyst and the parental role of the analyst becomes more highlighted in certain situations. And that tension has to be negotiated. And finally, obviously, this kind of work happens every day in child analytic work, every day. But this kind of work perhaps is more important in people who are more impaired and have more ego deficits and such. And you know, ego, as Freud says in Ego and the Id, is a precipitate of abandoned object cathexis. What does that mean? That means a day was that I didn't know how to drive a car. And somebody sat next to me, showed me how to drive a car. And then I tried and I learned, and that person is gone and I can drive a car now. So the skill that was residing inside of him came to reside inside of me. He was the object at that time of my libidinal attachment. That object is gone, and now that object is internalized and dissolved in the ego. Ego is the precipitate of abandoned object cathexis. But what if there were no objects? What if there were very few objects? What if there were no objects that facilitated development? Certainly, it does not leave a psychic hole. Certainly, aggression, revenge, hostility, idealization, guilt, inexperience, all the phenomena a cauliflower develops when one is deprived. Obviously, it does not leave a hole that a loveless child, you pour love and it gets filled up. Of course not. But there is something to it, that if the ego is weak because there were no development facilitating objects, then there is no precipitate. And that pushes the ego instinct to search for development facilitating experiences. And that is what I'm talking about. Okay. With this preface, let me suggest that there are 10 different interventions besides the customary interpretations, customary interventions of affirmation, validation, confrontation, abreaction, clarification, interpretation, reconstruction. These are traditional things and customary things and useful things. There are 10 other things which facilitate, predominantly work in facilitating development. And these 10 things are very important and more important in treatment of children, more important in treatment of young people, more important in the treatment of immigrants and exiles, and more important in people who have ego deficits. Now you know the difference between conflict and deficit. Conflict means I want to do this and I want to do that. I want to do this, but I shouldn't do this. I want to do this, but I'm afraid of doing this. That's conflict. Deficit is I don't know what to do. Certainly, a deficit, a plea for deficit can be used as a defense against conflict, of course. But there are genuine deficits also. That's the kind of person we are dealing with. Okay. Now let us think of those 10 interventions. Number 1. You know, these days, people use PowerPoint. And when you use PowerPoint, people think that you're telling the truth. If you don't use PowerPoint, people think you're just talking. So I have started using some PowerPoint, but I'm not like the pharmaceutical doctors who show 60, 70 slides because they can. I generally show maybe 5, because when it's written, we are people of the book. So when we see it written, we feel kind of cool and we feel that it is real. So just imagine that you're seeing a PowerPoint. So there are 10 things. Number 1, providing certain kinds of non-verbal experiences. Providing certain kinds of non-verbal experiences. Take the example of punctuality. You say to the patient, our sessions will be at 9 o'clock in the morning, and we will end at 9:50. In the United States, most analysts see patients for 45 minutes. I have always remained with 50 minutes, 50. So I tell patients, let's suppose we'll meet at 9 o'clock and we'll stop at 9:50. Okay, let's suppose that's the appointment. At 9 o'clock, exactly, I open the door to the waiter. Please come in. At 9:50, exactly, I say, I know this is very important what we're talking about, but unfortunately we have to stop. Or, our time is up and we will pick up maybe next time. Or, this is the kind of session we wish would go on, but it can't. Our time is up. And so on and so forth, whatever. Precisely starting surgically at 9 o'clock, surgically ending at 9:50. Now, obviously, I'm a human being. So are you. So are our patients. Sometimes patients will get late. Sometimes we will get late. Sometimes we will not start the session in time. Sometimes we'll not end the session in time. Hopefully, that happens infrequently. Hopefully, when that happens, we become curious. If it happens repeatedly with the same patient, we become curious about countertransference resistance and so on and so forth. But in general, we start in time, end in time. Now, what does this do? What does this do? On surface, obviously, clearly, and one doesn't have to be a psychoanalyst to understand this, it provides a sense of reliability and trust in the patient. That this doctor does what he or she says he or she will do. Now, many people, please understand, reliability is not a common commodity. You and I may have grown up with reliable parents, but a lot of people do not grow up with reliable mother, reliable father. And as a result, they have not developed what Erickson calls basic trust, which is the repeated and reliable satisfaction of the appeal cycle. The punctuality of the analyst establishes a sense of reliability in the ambience before a sense of reliability in the particular object, and lays down the groundwork for strengthening the ego in the realm of trust. That's one. Second, that beginning the session in time, precisely in time, is providing a good mother to the patient. Ending the session in time is providing a patient a good father. Now here, by mother and father, we don't necessarily mean male, female, please, for God's sake. Ferenczi was a very maternal analyst and Klein a very paternal analyst. Psychoanalysis is not done with genitals. Psychoanalysis is done with the heart and mind. And by the way, Jacob Arlo said it best. He says, a psychoanalyst needs a hard mind and a soft heart. A hard mind and a soft heart. So, when I say maternal and paternal, I'm not talking of man and woman. I'm talking of certain ways of being, which, as I said, compare Ferenczi and Klein. Faisaldi is far more maternal and Klein far more paternal. So by beginning this session, we provide the patient a good mother, because a mother is a given object. Shakespeare says, many quoted Shakespeare, so I'm now in good company, that Shakespeare says every man owes God a debt. True. But every God owes man a mother. That's also true. And therefore we are mammals. We are mammals. We are born out of our mothers. Mother is our creator and our primary object. And therefore, when the office door opens at 9 o'clock, come on in, come on in, come on in. It's like the baby phylogenetically pre-programmed to find a mother, finds it. Preconception, conception. From Jung to beyond. That is why beginning the session in time has to do with the provision of a good mother. Conversely, the ending the session has to do with providing a good father. Because there's an old Mexican saying, which is very nice. It says a mother should hold the baby like this and say, baby, look, this is the word. And a father should hold the finger of the baby and take him to the mountain and say, look, that is the word. Meaning the mother introduces the baby to the internal state of affairs. Oh, somebody's looking tired. Oh, somebody's getting very sleepy. You look like you're very hungry. The mother labels, introduces the child with the internal state of affairs, intensities of drives, names of emotions. There's an old paper by Amy Catan called Naming and Taming. So the father introduces, cuts this umbilical cord, extends the symbiotic orbit, and introduces the child to external reality. So at the end of the session, when the patient in analysis is totally absorbed in the matrix of transference and countertransference and in the self history, in the emotional internal life of the self, comes the axe. You have been a baby enough for a long time, and you have sucked on my breast for a long time, and you have been narcissistic and self-indulgent a long time. Now, go do your work. Be a doctor. Go be a lawyer. Go be an accountant. Go do your job. The father introduces external reality. It's from Mexican saying, the father cuts the umbilical cord, to Lacan. But it is that principle. So by punctuality, we provide a good mother and a good father. And we strengthen the ego's capacity for reliability and trust. That is a non-verbal intervention. Sometimes other kinds of non-verbal interventions can happen. For example, Ogden writes about interpretive action. Sometimes we have to interpret by action. Somebody who thought that they were so ugly, and their skin was so bad that I will never even conceptualize, even wildest dreams, think of touching them. Obviously, it went back to trauma, it went back to traumatic memories with the mother pushing her hand when she was trying to touch the mother as a little child. And then it went back to the aggression within the self, by which the touch itself has not only become masochistically tinged, but sadistically infested also. So there are all kinds of fantasies and all kinds of things to be analyzed about the touch. And the patient will get analyzed and then regress, get analyzed, regress, get analyzed, regress. Because there was an ego defect that causes the regression. So, which cannot hold on to an abstract situation and cannot give up the sadomasochistic temptation. cannot, refuses to, and is unable to. So now, at one point, some 5-6 years into analysis, after everything, every fantasy had been examined, interpreted, reconstructed, and such, the patient once again says, my skin is so bad, I'm so ugly, you will never even think of, you cannot forget about sex, you would never even think about touching me even. I couldn't take it anymore. So I put my hand forward, patient is on the couch. I said, no, first I said, you know what, let me ask you this question. And let me make the patient's name as Bharti. Patient name was not Bharti, I just making this up, you know. So I said, let me ask you, in your opinion, is this Dr. Jain talking to Dr. Akhtar? Or is it little Bharti talking to Mami? Trying to drive some wedge of reality in the thickness of the transference. Patient says, it is Dr. Jain talking to Dr. Akhtar, meaning this is a real matter of today. I couldn't take it. So I forwarded my hand. I said, on this wonderful insight, I will shake your hand. In an ironical comment, the patient got flipped up and extremely anxious and angry. You can't touch me, you're a psychoanalyst. You're not supposed to touch me. You're breaking boundaries, blah, blah, blah. I said, this is very fascinating. 1 minute ago, I was a good analyst and a bad person. And now I'm a good person and a bad analyst. And both the times you focus on the bad one. How come? That's very interesting. Patient says, I'm not interested in such bullshit. I said, why not? So do you see, this was a trial, what Ogden calls an interpretive action, an action performed in the service of making an interpretation. This is a non-verbal thing. This obviously worked in a different way. Then there is a concept called the now moment or moment of meeting, which child analysts have written about, and especially in the work of Daniel Stern. You know, and here is a situation: a masochistic patient, very masochistic, very self-depriving, and such. And we work. 2 years pass. The patient is now much better in many, many ways, in terms of relationships, in terms of management of money, in terms of management of her physical health, physical appearance, physical health, romantic relationships, and so on, financial situation. The patient is now greatly improved. But still, she tells me the following story from the couch, that one day, she said, yesterday, most amazing thing happened. You'd be proud of me. I said, what happened? She said, I was in the post office going to mail something, a package. I was going to mail a package with a friend, and the friend and I were talking. And the friend is in the same business that I am in. So we were talking about our business. And a young man, all of 21 years old, is standing behind in the line, interferes and says, no, 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 this business is not done this way. But by the way, the patient is highly accomplished and successful in her business. The young man, 21-year-old patient said, no, 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 this business is actually blah, 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 blah. Patient says, you'll be so proud of me what I did. I turned around and I said, you are a fucking asshole. And then the patient bursts in a laughter of great pride and raises her hand behind the couch like this for high five. And I reflexively hit her hand. Now, obviously, we don't touch our patients in regular treatment. We don't touch our patients. And we have to look for, later on, quietly, silently, consciously, and pre-consciously, we have to look for whether this physical contact with the patient turned into something else in the mind of the patient or not. Otherwise, this was a perfectly fine gesture. to not have hit her hand when she went like this would have created a kind of loss of libido, a kind of humiliation that would not have been good. You see, we deprive our patients, but we deprive them only to the extent that is good. It's like a surgeon. We give anesthesia when we are performing surgery, but not so much that the patient dies. Only the anesthesia that the patient does not wake up and does not die. Both things. Does not wake up, yes, but does not die, yes. Abstinence is only to the extent that the patient clinical moment tolerates. And the analysis is facilitated rather than impeded. So this is one set of ideas. One, oh my God, I have 9 more to go, Jesus. You know, whenever I begin a talk, I always think I have no idea what the hell I will say for 1 hour. And then, you know, turns out 1 hour is finished and I'm like halfway through. So I apologize, I'll try to be faster. This is providing certain kinds of non-verbal experiences. Second, validating patient's reality. Even if that reality involves projections. In fact, the more tenacious the projection, the more it needs the more the need for validation of realistic elements of that projection. I'll give only one example. I started analytic training in 1979 in the United States. Although 2 people of Indian origin, one from Bombay, one from Ahmedabad, had already trained in American Psychoanalytic Association and were certified by American Psychoanalytic Association and were actual serious practicing analysts ahead of me. I did not know them. They were not writing papers, and both of them were relatively reserved people who did not come to many meetings and were not writing papers. As a result, I did not know of their existence. So I developed this narcissistic delusion that I was the first and the only Indian psychoanalyst in training. This delusion, I think, also compensated me for the profound sense of aloneness in the profession. The profession was predominantly white and predominantly Jewish. I was brown, Indian, and Muslim. And it was very lonely for me. So the narcissistic delusion sort of became like a band-aid. Nonetheless, the pain remained. So in my analysis, I will often ask my analyst, do you think if I were white and if I were American and especially if I were Jewish, do you think there'll be greater chances of my becoming a more successful person in this field? Maybe a training analyst, maybe the editor of Journal of American Psychoanalytic Association, and so on and so forth. Now, my analyst did what all analysts customarily will do. Tell me, what is your fantasy of being Jewish? What does it mean that you're not a Jew? What does it mean that you're a Muslim to you? What does it mean that you're an immigrant, that you're brown skinned? What does it mean? What does it mean? What does it mean? What do you think all this has to do with the Jew and non-Jew, the white and brown, the American and immigrant? What does it have to do with you and your brother, who is a film writer and so on and so forth? What does it have to do with your childhood experience with your mother's love and father's love for your brother and your mother's love and father's love for you, the differences in that kind of love, in the amounts and qualities, blah, 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 blah. I'll get okay for a few months. And then I'll bring up the same question again. The repressed has a continuous pressure in the upward direction of consciousness. Then same analysis, I'll become okay. Then 6 months later, I'll ask the same question again. I must have driven the poor man crazy. But one day, I said, do you think it's possible that if I were white, American, and Jewish, I would be more popular and more successful and more famous in the field of psychoanalysis? And he said, I think so. I think that is possible. When he said that, a very peculiar thing happened. I got terribly embarrassed and I had nothing more left to say. So I remained quiet. So he says, well, now that I have acknowledged this, what did you get out of it? How do you feel about me now? And what percentage you think, because you're always saying percent this and this percent that, what percentage of this problem has been actual demographic and neurotic related to you and your brother? So you give a crazy person a chance, the crazy person takes a chance. So I said 90% reality and 10% neurosis. He banged his hand on the table. He said, no, 90% neurosis and 10% reality. But the very fact that he said 10% reality led to a very interesting transformation. I never brought this up again. Another 4 years of analysis, the matter was over. Now I could be analyzed about my rivalry, envy, jealousy, hate, love, admiration, contempt, and all those feelings towards my brother. Now I could be analyzed. I really became analyzable about that. Till the time this kernel of reality was not acknowledged, I was not analyzable. I was compliant. I was a good boy. I wanted to be an analyst. I wanted to be famous. I wanted to be loved by the institute. Yes, so I was compliant, but not really analyzable, not capable of modeling, not capable of utilizing those insights that a part of me vehemently and violently rejected. We cannot analyze somebody without acknowledging their reality first. You guys are in Calcutta. I know Minnie is in Bombay, but let's say in Calcutta. Suppose I'm in your patient and I say, I feel kind of awkward that I walk around on the street and I don't really know Bengali. I know a few words in Bengali and I can say a few phrases, but I feel sort of out of it. Because you have to say, yes, Dr. Akhtar, I can imagine that you would feel a bit out of it not knowing Bengali and living in Calcutta. I can imagine it can cause a bit of burden. First, then whatever. Do you imagine that my children speak Bengali? Do you see other patients leave my office who speak Bengali? Do you think my husband is Bengali? And all kind of shit will go on. But first you have to acknowledge that reality. Okay, 2 pieces. One, I said non-verbal provisions. Second, validation of patients' actual reality. Third, creating space for thinking. Now, thinking is not a congenital activity. Thinking is not a hardwired activity. Thinking is not a given activity. The capacity for thinking is, but not thinking. Here is one way to illustrate this. Walking on legs, walking is not a congenitally given activity. Please, for God's sake, don't ever think that walking is congenitally given. No. Capacity to walk is congenitally given. Walking is a skill that is evoked by the environment out of that capacity. So, for example, if a baby is thrown in a jungle and is raised by wolves and hyenas, when I was 10 years old, 11 years old, in a city called Balrampur. I don't know whether anybody from UP is listening to that or not. Oh, Pushpaji knows this. A city called Balrampur near Lucknow. there was a boy found who was called Ramu, and he had been raised by wolves. I was utterly fascinated as a child with that boy. Why is another story, which either I can tell on the couch or over drinks, not in this talk. So now I was utterly fascinated. Feral children raised by animals in jungles, never walk upright. They always walk on all fours. The capacity of upright locomotion is in them, but that capacity needs epigenetic evocation. Same thing with thinking. The capacity for thinking is inside us, but it needs evocation. It needs what Bion calls a container, what Winnicott calls a facilitator of going on being. The going on being is not only a physical matter, going on being is a mental matter also. So here's an example. I am 6 years old, I cut my finger. Blood comes out, I put my finger under water, bleeding stops. My mother is walking by. I said, Mom, look, the blood stopped. I'm going to become a doctor when I grow up. And guess what will be written in front of my office? She says, what? I said, there'll be a big board saying the doctor who stops bleeding. What does my mother say? My mother says, yes, that's a good sign. But maybe we should write the doctor who stops bleeding and helps many other problems. Do you see? She took my thought, she elongated my thought. That elongation, identification with that activity, creates the capacity to think. Many people have not had that kind of mother, or mothering environment, or grandmother, or father, or uncle, or grandfather, or culture, or subculture, or economic circumstances. As a result, their capacity for thinking becomes stunted. And it's our job as their caretaker, analytic caretakers, to facilitate thinking and create a space for thinking. So here is an example. A patient, female patient with great difficulty, with great shyness and great difficulty, and with much encouragement, reveals that she is horrified and ashamed and finding it extremely difficult to tell that she wants to have sex with me. I ask her, why was it so difficult? Why is it so difficult? Patient says, well, you are not a woman, you don't know. If I say I want to sleep with you, have sex with you, obviously you are a psychoanalyst, you are a doctor, you're going to say no, and I'll be humiliated. I said, if you had revealed this desire, I might not have said no. Now the patient gets nervous, which is good. Something is happening. Patient says, what do you mean? You'll say yes? That'll horrify me even more. I said, no, I wouldn't have said yes either. Patient says, what do you mean? I mean, there's yes and no. I said, no, I can think of at least 10 different answers in lieu of yes and no, which I might have given. She said, like what? I said, like, let's think about it. Or like, what would that do, you think? Or when and where were you thinking of doing this? Or why? What would be the purpose of this? Or I can go on. I can give 25 different answers. Patient says, but sooner or later you will say no. I said, do you notice what you're doing? You're going from A to C. I'm trying to stop you at B. You're going from fantasy to action. And fantasy to its closure. I'm saying from fantasy to desire, desire to fantasy. I'm saying, let us talk, let's see what images, what pictures, what determinants, what motivations, and what consequences do you have in mind? This is creating a space. That's one. Another example is a patient would say, speak in paragraphs. This is a male patient, he would speak in paragraphs. Literally, it looked like, I mean, if you could type it, nice paragraphs. Blah, 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 blah. Blah, 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 blah. And they're unconnected. And the paragraph almost always ends on the same sentence. Well, I have nothing more to say about it. Pause. Now, new topic. Another paragraph. Well, I have nothing more to say about it. Next paragraph. I have nothing more to say about it. Or sometimes a little variation. That's all I have to say about it. Or sometimes a smaller variation. That's all. This is how he taught. This shows no space for thinking. He's talking about what he already knows. But we are metapsychologists. We know there's an unconscious. We know that there's more to what the patient knows, what the patient doesn't know. And therefore, this person is not able to think further. I enjoyed my mother's comment when she said the doctor who stopped bleeding and does and helps other problems also. I liked it. It made me proud. It made me happy. But more importantly, it laid down the groundwork for thinking. And there are many such examples. I had a very, very special and very good mother, I must say. But anyway, so now this patient is unable to think further. So I said to this patient the following: Mr. X, whatever, I'm going to suggest something to you. Next time you are about to say, that's all I have to say about it. There's nothing more I can say about it. That's all. Try to add a couple of words to this sentence. Those words will not be yours, and you will feel inauthentic. But that's okay. When we are learning new things, including new things about ourselves, when you learn to drive a car, to play golf, to read a new language, we feel inauthentic. So you'll feel a little fake and a little inauthentic, and that's okay. But try to add the following verse. You are about to say, that's all I have to say about it. Just say, that's all that I know that I have to say about it. This will create a potential that there might be things about it that you still don't know. Okay. There are many other examples I can give, but point is made. So number one, providing certain kind of non-verbal experiences. Number two, validating the patient's reality. Despite or because projections involved. Three, creating and increasing, enhancing the space for thinking. Three, sorry, the phone keeps ringing, I'll just put it off. Okay. Four, helping patient find words for what the patient does not have words for. Now, I'm sensitive to language, perhaps more so than others, partly because I grew up in a very, very literary family where pronunciation, language, idiom was very important, where poetry was recited in middle of conversations and such. So I'm sensitive to language in that way. But an immigration has also made me doubly sensitive, because now I'm mostly thinking and working in a language that I did not grow up working and thinking. So that, and by the way, the best book to read about language and psychoanalysis is by the Italian analyst, originally from Argentina, but Italian, Jacqueline Amati Mehler, The Babble of the Unconscious. Anyway, there are words that exist in one language that don't exist in another language. Amusement is an interesting word and therefore an interesting feeling, or if interesting feeling and therefore an interesting word, which does not exist in Urdu, in my mother tongue. There's no actual equivalent of amusement. Uljan is a Hindi word or Urdu word for which worry will never be sufficient. Uljan, dilemma, worry. Same way, there are words that are not transmitted, number one, cross languages, but also there are words that are missing in families. Take this example, and a shocking example. There is words for adult male genital in Hindi. There is word for adult female genital in Hindi. There is word for a child's male genital. There is no word for a child's female genital. Now that creates a very interesting situation. That creates a very interesting situation, number one. Number two, that the words for genitals in Hindi, Urdu, and Punjabi, these three languages I'm familiar with because I grew up also in Delhi and Punjab, but mostly Lucknow. That I don't know about Bengali, Maharashtrian, Gujarati so well, but I suspect the same case maybe. And that is that the word for penis and vagina and for fucking, peeing, shitting, farting, that the word for these things are so obscene and so lewd that they undergo repression and sometimes actual absence. Many people do not know the words for it. I have had experience of Indian and Pakistani women in analysis in years in the course wanting to know what the female genital is called in Hindi Urdu because they never knew. It's a very interesting phenomenon. And even medical doctors all over the world are terrified of the word vulva. They call it vagina. That's not vagina. External female genital is not called vagina, which is what they call. Even doctors do this. So that when the words don't exist, it is our job to provide the words for the patient. Because without words, there cannot be mentalization. So that is another area. 4. 5. Continuing to work despite what appears reprehensible in the patient's experience. Just like those of you who have children, I certainly have children. I have children, grown-up children. Some of you might be younger than the age of my children. Who knows? You know, I have children. I have a son and I have a daughter. Now, children bring pleasure and pride at every step of their development and bring anxiety and annoyance at every step of their development. They please you and they piss you off. Both. That's a normal thing. That's part of life. So do the parents. Parents please children and parents piss children off. Obviously, it's not possible. In that, we don't have to be Freudian and Kleinian. Buddha knew it. Life is not possible without suffering, meaning without aggression, from inside or from outside. Our children sometimes do stupid things, shameful things, wrong things, unethical things, physically dangerous things, and so on and so forth. But we don't stop being their mother. We don't stop being their father. Same thing applies in the developmental mode of relatedness to the patient. Patient may say something very, very reprehensible. But we have to go on and survive and still be their therapist, their analyst. Patient says, I pick my nose and eat my snot. I say, tell me more about it. Now, if my cousin said to me or my nephew said it to me, I pick my nose, eat my snot, I said, get the fuck out of my living room. You know, That's a different thing. I'd be horrified. But I'm not my cousin's analyst. Patient says, I eat my snot. I said, tell me more about this. I'm peaceful. This is just a clinical data. What the patient is doing, what the patient is trying to evoke, who the patient is telling, why have the patient kept it hidden, how did it start? Those are my interests. What purpose does it serve? And so on and so forth. Patient says, I find my cat and I bite her claws, and then I keep the little chips of her claws and chew them as chewing gum. I said, tell me more about it. But how did this start? What do you think this is about? And to a very grotesque extent, a patient who had been in Vietnam War told me that he had shot a woman who was pregnant just to see whether the baby will fall up, fly up, or fly down, fall down, kill the woman. I was horrified, and later I was angry. But I was never lost sight of the fact that this was a regression, a state-induced, nation-induced distortion of the superego. And he was himself very remorseful. But you have to listen to this kind of thing and keep going on. Keep going on. We have to survive. You know, our child can come and tell us that they have committed a crime. We don't stop being their mother and father. Same thing. So far I've said non-verbal, providing non-verbal experiences, validating the patient's reality, creating and enhancing the space for thinking and for rethinking, helping the patient find words or where words do not exist, either because of bilingualism or developmental or cultural deficits. 5, continuing to work despite what appears really reprehensible material. 5. 6, understanding that occasional regression is a part of development. Development does not go A, B, C, D, E. It's not oral, anal, phallic, aripal, latency, adolescence, young adulthood, middle adulthood, and old age and death. That's not how it is. Sometimes people die first and then live. Sometimes people have adolescence when they are 45 years old. That scheme is for fortunate people. I mean, Bharti ji, this thing that people have made up called brahmacharya, grast, and vanaprastha and sannyas. These are not happening in everybody in that order. Some people start with grast and then they become brahmacharya in middle age. Some people start with sannyas in childhood. You see, these things are not so sacrosanct. That's it. Paradigmatic model. But in psychopathology, they are all altered. And also, regressions take place. Regressions. And those regressions have to be respected and not gotten frightened and quickly resolved. Some regression is part of development. A child learns how to tie shoelaces. 2 days later, the child says, I don't know how to tie shoelaces. Mommy has to do it again. Mommy has to do it again. The child goes up and down because with development comes separation and loss. So the child goes back. Same thing in analysis. So the regression is not only because of what Freud thought as a negative therapeutic reaction due to a guilty response to a correct interpretation, or what Klein thought as an envious attack. As an envious attack, I apologize. As an envious attack on the generative and helpful capacity of the analyst. Those explanations do apply. But a third explanation also is that improvement means losing the analyst. And the person doesn't want to lose the analyst. That auxiliary support. So the person regresses. So we have to understand that some regression in symptoms and character will happen from time to time. A person who dates crazy men, then with analysis, becomes better, finds a more reasonable man, breaks up, and then dates a crazy man. Don't get so out of shape. This is part of life. That's how it happens. Then the person will bounce back from it. So that's number 6. 7, enhancing personal agency. Personal agency. Do you see, this is a very, very important idea. And that is that actual intentionality. When does intentionality begin? You know, we are vulnerable to saying that intentionality begins from birth. Maybe, but maybe not. Or maybe the intentionality that is present from birth is rudimentary, weak, and focal. I mean, the day I was born, was Salman born that day? I mean, was I Salman on 31st July 1946? I didn't even know how to say the word Salman. I didn't know how to spell it. I didn't know how to sound it. Was I Salman that day? Or was I Salman in my mother's and father's minds only or mainly? There's a gap between the biological birth and psychological birth. And fascinatingly, the gap exists on both sides. It is the psychological birth in some ways happens later, like in the work of Mahler, and sometimes it happens earlier. If the parental fantasies are too strong, they have already created a child that they want to impose upon this child, and so on and so forth. So, but biological birth and psychological birth are not synchronous, hardly ever. Same thing applies to intentionality. And in adult patients, the absence of intentionality is largely defensive. Largely defensive. Oh, you know, this thought occurred to me. This thought occurred to me. They wouldn't say, I thought of this. This thought occurred to me. So in adult life, there's already intentionality. At certain pre-verbal core, there might not be. And some very early distortions of the self might be pre-intentional. But those are exceptional situations. The fact is, in adult life, things are intentional. Random things happen once in a while, but mostly intentional. As a result, when a person is disowning intentionality, such thought occurred to me, oh, this happened by mistake, you know, and so on and so forth. It's our job to enhance the sense of personal agency. You say, I'll be taking a week off in the first week of October. Patient says, yeah. I don't know. I mean, this word is coming to my mind, abandonment. Not, I mean, I don't mean that you're abandoning me, but the word came to my mind. The word came to your mind. How? By a virus, right? So it's our job to enhance the sense of agency. Okay, let us imagine for the time being that the word came to your mind and you did not bring it to your mind. Let's imagine for the time being. What do you make of this word now? Now that you have it, let's think what you do with it, and so on. And where do you think words come from? And so on and so forth. So enhancing personal agency. Number 8, restraining psychoanalytic and interpretive greed. Psychoanalysts, especially those who are young, get frightened if they don't interpret. They think, oh my God, I'm not becoming a psychoanalyst. No, being a psychoanalyst means knowing when to interpret. And therefore, by implication, it also means knowing when not to interpret. For instance, a patient of mine, right before her session, an hour before her session, found out that she was suffering from an extremely dangerous and fatal disease, which was going to kill her. And the fact is, she did die within a year. She did actually die within a year. That day, when she found out, she comes, she had an appointment with me. She comes, and this was a psychotherapy patient, not an analytic patient. So she was sitting twice a week on the chair. So she comes and she's crying. And as she's talking, she moves her hand like this, and from a nearby little table, picks up some little physical object. And as she's talking and crying and sobbing, she's like caressing that physical object and talking and crying and sobbing. Okay. Now, as a psychoanalyst, of course, I'm curious why she's touching this physical object. Of course, I have a hypothesis, tentative, perhaps not correct, perhaps not exact, but I have a hypothesis. Does she want to touch me? Does she want to hold me? Does she want to be held by me and turning the passive into active? Does she want to leave traces of her physical and biological self and psychic self in that physical object so that she'll never part from me? Does she admire an inanimate object more now than in life, because inanimate objects may live longer and may be safer from this disease? We don't know. There can be 25, 30 different meanings. But the question is, should I bring this to her attention? Should I point out that she is touching this physical object? Should I invite her to speculate what it means? Should I offer a potential meaning? And my answer is no. 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 Bismillah Khan may be staying in a hotel in Vienna and his Shehnai may be sitting right next to him. But that does not mean he should start playing the Shehnai in the hotel room. There are times we know that interpretation is correct. There are times we know interpretation is not needed and ill-timed, and we have to wait. This is the difference where Klein and Balint parted company, and Freud and Ferenczi. And in fact, Freud has written and Freud has practiced. But it started with Freud has written, Freud has practiced, went to Freud and Ferenczi, went to Balint and Klein, Winnicott and Klein, Kernberg and Kohut. This is the split. And the split has to do with that at the point of regression and emotional flooding, should we become more interpretive or less interpretive? That's a very important thing. The best thing to read, in my opinion, are actually two things came to my mind. One is a paper by Bjorn Killingmo, a psychoanalyst from Norway, is written as Killingmo, 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 written as Killingmo, but actually I found out pronounced as Chillingmo. It's a paper in 1989 IJP called Conflict and Deficit, Implications for Technique. And there's a book by Kenneth Wright, British analyst, called Vision and Separation. In that book, there's a chapter on the maternal and paternal poles of technique. When Freud started psychoanalysis, psychoanalysis was motherless. It was all fatherly psychoanalysis. These dreams mean this such and such thing. Don't you see what you're doing shows blah, blah, blah. Then with Winnicott, it became fatherless. It became all motherly psychoanalysis. I know it hurts you. It's very painful. I know that what you're looking for is, understandable and such. It became all fatherless. And even today, a bunch of psychoanalysts practice only fatherly psychoanalysis and have no mother in the room. And there are a bunch of psychoanalysts who practice motherly psychoanalysis, have no father in the room. Not a good idea. So one has to restrain analytic greed. Sometimes the patient needs mother, sometimes the patient needs the father. Sometimes the patient needs affirmation, validation, empathy, and attunement, and staying with the patient and patience. Sometimes the patient needs confrontation, clarification, and interpretation. And one has to restrain one's interpretive greed. Number 9, seeing goodness in the patient. Seeing and discerning and never losing the sight that the patient, like everybody else, is basically a good person. Now, in Freud and Klein, human beings are basically bad. They have to strive to become good. In Freud, by not committing incest, not committing parricide and sublimation. In Klein, by recognizing their own contributions to the problems and by offering reparation and having gratitude. In Winnicott and Balint and Ferenczi and Kohut, human beings are basically good. And they have become bad as a result of hurt. We have to see this inner goodness in the human being. I have written a very long paper, in fact, 2 parts paper on human goodness. Its place in psychoanalytic theory and its technical relevance. So I wouldn't go in great detail because we are already over time, but the important thing is to keep in touch with the patient's goodness. And seeing that there is something, because remember in metapsychology, there are 5 principles: topographic, economic, structural, genetic, and adaptive. Meaning every behavior is trying to do something worthwhile, something that is good for the patient. A patient drinks too much. A patient smokes too much. Okay, that's not good. But if he doesn't smoke and doesn't drink, he'll beat up his wife. He'll be bored out of his mind. He will drive recklessly. He will do something else. This is better. And we have to see that this is better. Okay. And there are other things. I could go, if there was time in discussion, I'll give more clear clinical example of how to see goodness in the patient. And finally, number 10, not avoiding the topic of death. Do you see, it is a common mistake on the part of many analysts that only people who are terminally ill or only people who are old talk about death in analysis. That's not true. Everybody talks about death in analysis. Especially in the termination phase. When a patient talks of death, birth and death, we always consider it as a metaphor. But we never take that as a reality. The fact is that death is an important part of life. And to let the patient finish an analysis without ever talking about their death and the analyst's death is to perpetuate a narcissistic delusion of immortality, which is not doing the patient a good service. These 10 things, providing non-verbal experiences, creating a space for thinking, validating the patient's reality, helping patients find words for which the word patient does not have words, continuing to work despite what appears reprehensible in patients' thought and behavior, remembering that an occasional regression is a part of development, enhancing personal agency, restraining psycho-interpretive greed, seeing goodness in the patient, and helping the patient talk about his death. These 10 things, when they coexist with and not replace in a loud and shrill manner validation, affirmation, confrontation, clarification, abreaction, interpretation, reconstruction. In the setting of anonymity, neutrality, and abstinence, constitute a comprehensive analysis. And I have tried today to share with you my view of how the clinical work can and should be done. Thank you for giving me the opportunity. हो चुकी अब शायरी, लफ्जों का दफ्तर बांध लो. आपने कहा था ना कि पोएट्री, तो मैंने कहा कि I didn't recite any poem, so I'll recite 2 lines. हो चुकी अब शायरी, लफ्जों का दफ्तर बांध लो, खत्म हो जाए ये ज़मीं तो अपना बिस्तर बांध लो.
Thank you. क्या बात है, yeah. So Minnie, it's up to you. You will now you have to invite questions from the floor.
You're muted, Minnie.
Yes, thank you so much, Dr. Akhtar, for taking us through Freud and Ferenczi and their conflict, and Klein and Freud and Klein and Winnicott and Balint and basic fault, and somehow to bring all of this together under the basic line of what we need to give to our patients, other than just interpretive action. But of course, all of it can also come under interpretive action as we interpret not necessarily to the patient, but to ourselves. And interpretations can have a form not only just about what's given to the patient, but how simultaneously we are also interpreting to ourselves what we experience. And these form a kind of very strong, a bit Bionian grid, maybe one could even say, whereby we will think about what we feel from moment to moment, how we will respond, and to be a bit more thoughtful also, simultaneously for patient and us as to the intersubjectivity that's taking place in the here and now with both of us.
Yes, exactly. And also that any and all of these interventions can get caught up in libidinal sides and aggressive sides, and then give rise to further fantasies. Why did my analyst say such and such thing? Why did he go like this, right? So anything can get caught up in other instinctual. I'm only talking of the ego, handling the ego instinct. But that does not rule out the other two. They are there and they are more powerful. They're aggressive and they're sexual. So anything can get further caught up, and then it would need a reverse step to reanalyze the impact on the affective and fantasy life of the patient. You're right. And the point about these things emanating from interpretations within the analyst, I think is a very fine and sophisticated point. I fully agree with
that. We'd be very happy to have we are seeing things on the chat, but it would be nice if people can share their responses and maybe their reveries as they've been hearing Dr. Akhtar speaking. Bharti, we already have someone raising their hand. Dr.
Shubhranshu. Yes, Shubhranshu, you can go on.
Okay. Is she visible? Invisible? Invisible. At least she should be at least audible.
Shubhranshu, can you unmute yourself?
Yes, now I can unmute. Thank you for allowing me. This is, I felt a magical session. The words were doing magic with my minds, because he cautioned right at the outset that I should not listen too seriously, but I did not follow his instruction, and the consequence happened. I am all at the same time lost and curious to learn more and listen more. So out of that curiosity, out of that naive curiosity, my question is, during a therapeutic session, whether I am in the position of an analyst or in the position of an analysand, how to decide which is the right moment of providing or receiving interpretation, or just not to? Are there specific markers or indicators? Thank you.
You know, I mean, on one hand, I can get out of your question by being cute. And that cuteness would not be entirely wrong. For example, I could say, well, when Pandit Ravi Shankar is playing sitar, does he have a right moment to move his hand this way? You know, and therefore give you an elliptical, mystifying answer, which is not incorrect, but doesn't actually tell you anything. You know, basically says it's a matter of intuition and experience. And that is not incorrect, that is correct, that is how it is. On the other hand, I think one has to somehow learn. I mean, Pandit Ravi Shankar was also, one day did not know how to play sitar, and then he learned, right? Same way, everybody has to learn. So we have to have knowledge and experience before we can leave knowledge and experience and commit an act of faith, or before knowledge and experience become so diffusely internalized that things become more reflexive and automatic. So one rough guideline, please understand this is a rough guideline, and that is the patient says, let's suppose, I'm making this up. Let's suppose the patient comes in and says, I had a terrible fight with my boss, you know, and my boss really pissed me off and he hurt my feelings and blah, 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 blah. Now, we're listening to this. As we're listening, we are also thinking two other things. This boss, does this boss stand for me? Second, we are thinking, this boss, does this boss stand for his father? So we have this triad of current reality, transference, and genetic past. So we have to interview this, but we are quiet. Okay, we listen. Now the patient, so we might say, what actually happened? So the patient talks, blah, 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 blah. Okay. Then when the patient says, and at that time he looked at me with this kind of glance which pierced my heart, or some such thing. Now we remember that about 3 months ago, patient was talking about that my father looked at me with a glance that pierced my heart. That's the phrase he had used. So we might say, it's interesting that you use the phrase, pierced my heart, the glance that pierced my heart. This phrase is familiar to me. You use this in context with your father also. So now we are sort of like walking on a ramp and deepening the material and expanding the material, right? So generally, one story is not enough to interpret. We have to have a second story, and preferably a third, you know, that we have to see. So my first ever supervisor in psychoanalysis told me a rule, and a rule obviously is something that is to be listened for about 10 years. You know, now this is supposed to be taken lightly. Rules are for 10 years. After 10 years, you know that they are guidelines. He said, don't say anything for first 20 minutes of the session. Now, I followed it like a blind little boy for 10 years. This doesn't mean 20 minutes, for God's sake. It means listen to the patient. Let material evolve a little bit. Don't be in a rush. So on one hand, the example of Ravi Shankar, Pandit Ravi Shankar stands, that these things come with experience. See, there's an arc. The arc is this. We listen, we hear, then we listen, then we understand, then we sort out, then we decide, then we speak. तो ये पूरी एक आधा चांद है ना, ये crescent, कि देखो इधर से we hear, then we listen, then we understand, then we theorize, then we sort out, then we decide, then we speak. अब ये जो crescent है, ये बिगिनिंग में कॉन्शियस होता है, लेकिन हल्के हल्के जितनी प्रैक्टिस करते जाओ, जितनी बार देखते जाओ, जितना एक्सपीरियंस हो, जितनी गलतियां करो, उससे भी सीखता आदमी. तो gradually it becomes sort of a reflexive thing. So both things, both comments are, the moment of interpretation will come to you with practice, but meanwhile there shouldn't be a hurry. There should be an explication of the first story, a linking of the second story, and interpretation at the time of the third story. This is not to be taken literally, but roughly.
Thank you so much.
Yes, Timothy.
Thank you. Thank you very much, Professor Akhtar. And also thank you once again to the Indian Society for hosting these marvelous lectures. I wanted just to ask, from the point of view of ego deficit and these development enhancing interventions, is there a particular difference in approach to enactments that you would have?
Let us go back to that example where this masochistic woman who had developed the courage bit by bit due to analytic work, and had said that I told that boy that, oh, you're an asshole, right? And then she raised her hand behind the couch and I hit her hand like that. Now, was that an enactment? So that's one question in response to your question. The second thing is that sometimes a developmental tendency, a developmental potential which would have been normal had been thwarted and derailed and aborted. And due to our interpretive work, the tendency resumes. At that time, when it raises for the first time, it may appear an enactment, but it does not require interpretation. It requires holding an affirmation. For example, another extremely self-depriving person, extremely abject self-deprivation, in presence of financial resources. So it was not a matter of poverty. Abjectly self-depriving, not only in terms of day-to-day accoutrements of life, but also of relationships, of pleasure in any form, and so on and so forth. I moved an office. I was in one building, and then for various reasons, I was in another building. So the second day of my move, or third day of my move, she came and she said, as she walked in, this painting, can you please get rid of this painting? I hate it. I can't look at this stupid painting. Now, I was quite taken aback because this was a person, who was so self-depriving. And wow, what degree of entitlement. So I said to her, thank you so much for asking me to do something for you, because I know you're not the kind of person who asks people to do things for them. So it's clear that something very good has transpired between you and me that has led to this capacity. Now, let me tell you one thing. I have arranged this office in a certain way. I spend a lot of time in this office, and this office is dear to me. So I'm not going to remove the painting because I like it where it is. But what I am going to do is to take the painting off from the wall and put it under the couch for your sessions. Now, please understand, do not mistake that I was not curious what was in the painting that turned her off. Why did she want me to remove it? What would be the impact of my removing it? What would be the impact of my not removing it? What was she testing? What was she asking? What would it mean? All these questions were in my head, but I chose to not utilize them for now. I took the painting, I put it on. It took about 3 weeks, 4 weeks, 12 sessions, 15 sessions. Patient comes, walks in, notices that the painting is not there, it's under the couch. Patient says, listen, hang that goddamn painting up. Once that painting was up, we were able to analyze this. So the answer to you is either that we handle enactments differently, or the answer is we do not consider them. And I think the answer is somewhere in that tension. But now I have a question. Since you thank people in Calcutta and everybody, where are you speaking from? Where are you located?
I'm unmuted. Yes, I'm in Australia. I'm in Sydney.
Oh, wow.
Representing
Please give
Australia.
my regards. Please give my regards to Maria Teresa Hook.
Absolutely.
I'm
Thank you.
extremely respectful of her.
Thank you.
Yes.
Yes, Anshu, you want to say something?
Yeah, so first is like deep gratitude to Mr. Akhtar. I'm just so amazed at your range and your evocation, and it's so helpful to me as a young trainee in psychoanalysis. And so deep gratitude, because I also come from a Kleinian tradition, so deep gratitude. But I know you are not discussing aggressive instinct today. You are focusing on the self-preservation and, that part you are. But, I was struggling with a patient. She was a 28-year-old girl. And the more she revealed about herself, the more I hated her. Because, she'll say such terrible, horrible things about very close, people in her family. And so I want to ask you to talk about seeing goodness, maybe give an example of that, but also maybe help me a little bit of how do you deal with sometimes not being able to see goodness.
Yeah, I mean, look, there's a whole topic now. You're talking about countertransference hatred, right? The countertransference hatred, like any other countertransference experience, is co-created, right? That partly that the patient is looking to be hated, and patient is creating a bad object in you by reporting certain things. The patient learns how to evoke goodness in the analyst, how to evoke hate in the analyst, right? Because the patient needs that hate. So one is the way of thinking is that what is the patient getting out of this hate that I'm experiencing? Why is the patient wanting me to hate? Who is the patient making me into? What would happen if I hate the patient? What other experiences will get derailed and such? Is this hatred really hatred? Or is this hatred a defense against something, right? So there are all kinds of complicated and nuanced questions that arise, both about the patient and about oneself. Also, that am I hating this patient because I hate all 4 patients I saw today? Then there's something wrong with me, I'm not well. Or do I hate all patients every day? Then there's something really not well. Or I was okay with the 3 patients and I'm hating this one. That means that there's something in this interaction. And therefore, what is being created and why, for what purpose, and what is being warded off, by this experience, both in the patient and in oneself. So it's a complicated issue. The more specific answer can only be given after knowing more further details of the case and of the session. Which I don't think is a proper forum to go into, for the sake of confidentiality, etc. But certainly, for the time being, you have to sit on it. You have to sit on it. You have to bear it, and you have to think, about these questions. Who is she making you into? Why does the patient need a bad object? What is the patient warding off? What is the patient discharging? Who has the patient become identified with? Who is the patient making you into? And so on and so forth, right? Always keep, if you keep two papers in mind, two ideas in mind, you'll never be messed up. One is the concept of overdetermination, 1895 Freud, that everything is caused by many things. Nothing is caused by one thing.
Yeah.
And 1936, Robert Welder, the principle of multiple function. Everything has many purposes, many aims. Everything has many origins and many aims. If one keeps that in mind, one can bear things. And then one golden rule, which I learned, I'm now 75. This rule appeared in my mind only about a year and a half ago, and it's not a rule, I'm joking. And that is, when a patient becomes obnoxious, which sometimes they do, think of them as a relative. Think of them as your brother or sister. Think of them as your son and daughter. And when a relative becomes obnoxious, think of them as a patient. And both these positions will help you bear the situation better.
Thank you so much. Yes. And the second part, give an example of somebody, goodness, that seeing goodness in a patient. You said you give an example of that.
Okay. Do we have time? I'll ask the chair. Minnie,
Sure.
do you have time? Can we give an example? Or are we out of time?
No, we still have time. Minnie, you're muted.
Okay. All right. So here's an example. Where did this young lady go? I was looking at her. She was listening. There she is. Okay. So here's an example. Take this example. A 71-year-old man is walking near the ocean, and he sees some young boys and young girls who are like 18 years old, 18 years old, most likely just finished high school, or maybe in the last 12th grade of high school. And they're playing volleyball. On one side, there are 5-6 boys, and one side, there are 5-6 girls on the beach. And they're in their swimming costumes. And the boys wearing trunks, the girls wearing swimming trunks or bikinis. He's 71 years old. He finds himself looking at these girls and wants to have sex with them. And then gets filled with disgust for himself and guilt. So he tells me, he says, I looked at these girls and they were so attractive and I wanted to have sex with them. And then I said, oh my God, what's wrong with me? I'm 71. They're like my grandchildren. What is wrong with me? How sick I am, how disgusting I am. And look at these boys. They're playing volleyball and they're not thinking of having sex with them. They're just playing. And look at me, what a dirty old man I am. So I said to him, I can have empathy. You're describing 3 experiences. You're describing the experience of sexual greed. You're describing the experience of remorse and guilt. And you're describing the experience of admiring those boys and their innocence. I can have empathy with some of this. But one thing I'm still left puzzled with, and that is, how are you so sure that those boys were also not thinking of having sex with these girls? Do you see the point? What I'm trying to show the patient is that his idealization of those boys and thinking that those boys are all only sweet and innocent is a projection of his own good self that he cannot bear inside of himself. You see what I'm trying to do? That, you see, when Mrs. Klein described projective identification, because projective identification was popularized by Dr. Otto Kernberg in USA, who was dealing with borderline patients, it got mistaken to be as a splitting of the self, externalization of the self, depositing of the self in somebody else and manipulating them to live out that part. but only in the realm of lust, envy, greed, fear, hate, malice, and such. That is only one side. Projective identification can also happen of goodness, creativity, robustness, playfulness, innocence, kindness, generosity. If in a particular family structure, when a child is being brought, these qualities are looked down upon. Please understand, in vast majority of families, hate, lust, envy, jealousy, greed are looked down upon. But there are also families where intelligence, kindness, goodness, love can be looked down upon and derided and mocked. Then that part becomes ego distorted. And that has to be deposited into others, the positive projective identification. There's a paper by Alexander Hamilton on this topic. And I think Miss Freud's concept of altruistic surrender partly touches upon this. That the point is that projective identification refers to that aspect of the self that is unbearable and unmentalizable. This man cannot think of himself as good. He always, every session he was telling me how bad he is. While I loved him, I found him immensely a decent human being. Decent human being, good human being, funny, witty, charming human being. I loved him. I look forward to his visits because he had deposited his goodness in me too. You know, you see what I'm saying? So I could, by questioning his assumption that those boys were so innocent, that is idealization of those boys, which is his own goodness deposited in them. Now, I know it's not evening for me, but it's evening for you. So following Pushpaji's reminder, maybe we should end, and I'll end on a share. It says, कहने को क्या बचा है, हर एक बात हो गई. कहने को क्या बचा है, हर एक बात हो गई. आओ पिए शराब, क्या बात होगी.
जी नहीं, अभी तो कहने को बहुत कुछ बचा है. अभी यहाँ रात हुई, आपके यहाँ तो दिन है. अभी कहने को बहुत कुछ बचा है. Anyway,
thank you for inviting me. Thank you for inviting me.
Can I just say something, Salman? That I think it was exactly in Playing and Reality and Location of Cultural Experience where Winnicott talks about on the seashore of endless worlds children play.
Yes. Yes.
And I thought that is precisely what we did today with this coming in and out of realization, of confusion of tongues, beginning
Yes.
to think about frenzy. And it was really a very, very thought-provoking and exciting 2 hours.
Thank you, thank you, thank you. Thank you so much.
Thank you, Pushpa and Bharti, for arranging it for us. We all are greatly benefited by these exercises.
And
thank you for chairing the session. And of course, and we have been almost mesmerized by Dr. Akhtar's lecture. And thank him very much. I hope that in future also sometime he would agree to come to accept our invitation and give us such delightful lectures.
Of course. Okay. Thank you very much. Thank you, Bharti.
Thank you. Bye.
Thank you. Thank you, everybody.
Bye-bye.
Thanks for being here. Hope to see you all again in October.
Thank you.
Thank you, Dr. Akhtar. Thank you, Minnie.
Bye-bye.
Thank you, everybody.